Hello, in this section I will talk about ERAS, that is Enhanced Recovery After Surgery. So what is ERAS? ERAS is multimodal multidisciplinary protocol which is practiced for various surgeries to enhance or expedite the recovery after surgery. Now we call it Enhanced Recovery Pathway or Fast Track Pathway. So in this section, I will talk about what are those multidisciplinary or multimodal strategies which we have to practice. And there are like 15-20 evidence-based advice to practice for ERAS. And as many as we incorporate in one patient, the chances of expediting recovery would be faster. So what is the goal of ERAS? The goal of ERAS is to go for all those interventions which would minimize any complications in the patient, which would maximize total pain control, prevent any fluid overload, prevent any stressful condition for the patient. So thinking about all these things in mind, the goals of ERAS would be to minimize the surgical stress response. Now we have different approach for the surgeries. We have open laparoscopic surgeries, we have we have laparoscopic surgery, we have laparotomy, we have robotic assisted surgery. We all know that for laparoscopic approach and for robotic assisted approach, the stress response is definitely less on the patient, which would fasten the recovery. So it is always advised in ERAS protocols that the surgeries which can be done laparoscopically laparoscopic approach should be practiced rather than the open approach to minimize the stress and the tissue trauma. Then reducing end organ dysfunction. During pre, intra and post-op, all those interventions should be practiced which would cause protection to all our vital organs, prevent any end organ dysfunction, especially keeping in mind kidney. Then providing optimal control for the post-op pain. Post-op pain is one of the major reason for prolonged stay in hospital after surgeries. So if we have strategies right in the pre-op, intra-op and the post-op period to manage this pain, if we have a plan to manage this pain, then definitely the pain control would be better and patient would have a better satisfaction and a faster recovery. Then decreasing the hospital length of the stay. So by decreasing any complication, the hospital length of the stay can be decreased. One of the most common reason for post-op prolonged stay in hospital is post-op nausea, vomiting or post-op fluid overload. So all the strategies which can minimize these complications is practiced in the ERAS protocol. So what exactly is your key component of ERAS protocol? So we have 15 to 20 evidence-based strategies which have been suggested to implement during intra-op, your pre-op, intra-op and post-op period. And as many as more interventions of these strategies we practice, the chances of the faster recovery would be more in the patient. So we have 15 to 20 evidence-based strategies, right, to be practiced in preoperative, intraoperative and postoperative period. Intraoperative and postoperative period, right? So let us talk one by one in all those three periods, pre, intra and post-operative period. What are the strategies which would make the recovery faster? So let's start with pre-op strategies. So what are the pre-op strategies? Well, pre-anesthetic evaluation is the time to start implementing the ERAS protocol. So when the patient comes for pre-op, let's say a checkup, we need to look for the comorbid conditions in the patient and we need to optimize the comorbid condition as much as possible depending upon the level of or stress by those comorbid condition and also how much time we have for the surgeries, how fast it is required to get the surgery done. So depending upon how elective is the surgery and what is the comorbidity, we should plan the optimization of the comorbid condition of the patient. Better the optimization, better would be the outcome in the patient. Then prehabilitation. Now prehabilitations, there are some measures which are taken in pre-op period which would improve the recovery of the patient. I'll talk about it a little more. Then patient and family education and discharge planning. Now, lot of patients, we cannot practice the ERAS protocols, or we cannot discharge the patient faster if they do not have a good, let's say, family cover, or good, let's say, they don't have support at the home to look after them. So we need to educate the family and the patient regarding the care which would be required in the patient. Plus, we should also at this point of time tell them about their level of how much pain they are expected, what kind of pain control we can provide to them, what are the options. So proper education of the patient and the family is required. Then avoidance of prolonged pre-op fasting. This is very important. Now, a lot of surgeries, very long hours of pre-op fasting. Now, that not only causes intra-op hypovolemia, increases the risk of post-op nausea, vomiting, it causes a lot of problem in the patient. So, optimum guideline, the guideline which has been provided, which is, we should strictly follow those guidelines for pre-op fasting. Then, pain management planning. Pain management planning is not something which we have to do in post-op period. It has to be started in pre-op period. So, the concept of multimodal post-op analgesia has been changed to multimodal periop analgesia. The concept has been changed. So, right from the pre-op period, we start doing the things which would minimize the pain, and we call it preemptive analgesia. That is analgesia before the pain stimulus. So, I'll talk about the pain management planning, and for every patient, right, for minor procedure, moderate procedure, or a procedure in which we expect a lot of pain, every patient should be given the oral acetaminophen 1 gram at least 2 hours prior to surgery as a preemptive analgesic, and COX-2 inhibitor if patient doesn't have a contraindication for it. But this strategy is nowadays being applied for something called preemptive analgesia, right? And for selected patients who are at risk of post-op thromboembolism or peri-op thromboembolism, then in those patients, we have to give prophylaxis for thromboembolism by subcutaneous heparin, right, administration. So it is not given to every patient, it is given only to the selected patient, and it should be timed in such a way that 30 to 60 minutes prior to surgery. So let us see prehabilitation. So what is this prehabilitation? What we do in prehabilitation? Now in prehabilitation, a lot of things are practiced, like exercise, chest exercises, then your increasing the stress tolerance level of the patient, smoking cessation, alcohol and substance abuse education. So in prehabilitation, we have a lot of strategies like smoking cessation. Now this is the best period to educate the patient regarding the ill effects of smoking. Then nutritional supplementation. Now patients who are very cachexia or who are not adequately, the nutrition is not adequate, the chance of recovery is little slower in those patients. So nutritional supplementation has shown to do wonders in faster recovery. So smoking cessation, nutritional supplementation, right? Then your exercise program, right? Physical exercise program, including the chest exercises, right, has definitely improved the lung recovery. Now, interventions to improve the cognitive function of the patient in older age group. So, interventions to improve the cognitive function. Now there are a lot of, let's say, interventions which can improve the cognitive function of older patients, like using the letting them play puzzles or sudoku, etc. We need to start implementing it here itself. That would be better for the patient in let's say his whole life as well. And then we need to do everything which we can do to reduce the stress. So stress reduction. So all these are components of prehabilitation. And a lot of studies have shown that prehabilitation has done wonders in fast post-op recovery, like in Whipple's procedure, etc. Proper nutritional supplementation, proper exercise for chest has expedited the recovery like anything. Then, as I said, patient and family education. Patient and family education regarding the expected level of pain control, regarding the post-op care which patient will require once discharged has to be done. So, patient and family should be educated regarding level of pain control, then level of intervention, and post-op care required, and requirement of post-op support, post-operative support. You cannot expedite the recovery if you don't have the support of the patient's family, because patient would require some amount of support once the patient is discharged quicker than routinely what we take more time to discharge the patient, right? So all these things should be done. Then preoperative fasting. As I said, there's a huge role of pre-op, minimizing the pre-op fasting duration. So what is the ASA fasting guideline? The guideline says that 2 hours for the clear fluid, 6 hours for a light meal or liquid diet, and 8 hours for full fatty meal. Now we should strictly practice it. We should ensure that patient is taking the sips of water at least 2 hours prior to surgery, or let's say a clear tea, or let's say there is tea without milk or tea without coffee, coffee without milk, etc. is allowed to the patient 2 hours prior to surgery. So preoperative fasting should follow strictly the ASA guideline. Now, why we need to do this? We need to do this to avoid hypoglycemia. We need to do this to avoid hypovolemia, right? So, clear fluid should be encouraged as much as possible, encouraged for at least 2 hours prior to surgery, right? Now, why should we do this? We should do this to avoid dehydration, and hypoglycemia in the patient. Now, if patient would be dehydrated, definitely intra fluid requirement would increase, and all the complications of fluid overload would be there in the patient. So we have to encourage the patient as much as possible to take the clear fluid, and also to avoid the post-op nausea vomiting, postoperative nausea vomiting. And nowadays there is a suggestion that pre-op fasting. Now, pre-op fasting 2 hours has been allowed for the clear fluid. In this, instead of taking plain water, carbohydrate rich clear drink should be taken. Now, this would not only maintain the hydration, that would also maintain the energy level of the patient without increasing the risk of aspiration. So, carbohydrate rich drink, right, is recommended. Why? This will make the fasted state to fed state. So carbohydrate rich drink is recommended to make fasted to fed state. Now this will not only decrease post-op weight loss, this will decrease post-op weight loss. It will also expedite the recovery. Now let us talk about the pre-op medication. We give our patient a lot of pre-op medication to minimize the anxiety and for other conditions as well. So choosing our pre-op medication should also be optimum. First, the pre-op medication nowadays should not only be the medications which are to allay anxiety, or if patient has pain, then we provide analgesia. Primitive pre-op analgesia concept is there. Primitive multimodal analgesia should be there. So multimodal opioid sparing agent should be used. So first thing, in primitive analgesia, we have to go for some pre-op medication for primitive analgesia. So multimodal opioid sparing agent. So we should go for opioid sparing agent, because opioids, lot of complications, side effects of opioid would make the discharge little difficult. Opioid increases nausea, vomiting. Opioid can cause respiratory depression, right? So multimodal opioid sparing agents. So what we should give our patient, as I said, acetaminophen and oral COX-2 inhibitor is given to all the patient. Acetaminophen 1 gram at least 2 hours prior to surgery. At least 2 hours prior to surgery. And oral COX-2 inhibitor again 2 hours prior to surgery. Now this is depending upon, patient shouldn't have any contraindication for it. Then apart from this, antibiotic prophylaxis. Now risk of perioperative infection is always there. So if we give antibiotic at the optimum time, the chances would be minimal. And if the surgery interop is getting prolonged, it should be mentioned when the antibiotic was administered and the dose should be repeated. So antibiotic prophylaxis. Now what is the optimum time for antibiotic prophylaxis? 30 to 60 minutes prior to anticipated surgical incision. So 30 to 60 minutes prior to anticipated surgical incision, right? We should give the antibiotic prophylaxis. Okay, then we should go for the thromboembolism prophylaxis in patients who are at high risk for thromboembolism, right? So venous thromboembolism prophylaxis, 30 to 60 minute, right? Prophylaxis 30 to 60 minute before surgery. So what do we do for give for it? 5,000 units heparin, or we can go for mechanical prophylaxis, right? Okay, so these are the agents which we have to choose. We have to allay the anxiety in pre-op period. We can use lot of techniques for that, like music therapy, etc. And or we can use some drugs as well. The choice of the agent for as an anxiolytic should also be very, very cautiously done, because there are some drugs which produces a prolonged sedation and can cause delirium in post-op period and can delay the discharge. So we need to know the drugs, the agents to be minimized or avoided during the pre-op period. So gabapentinoids. Now the routine use of these drugs are not recommended, because they increase the post-op sedation, they can cause post-op respiratory depression. So routine use not recommended, because they can cause the postoperative sedation, they can cause respiratory depression and delirium and dizziness, right? So the routine use is not what is recommended. Then commonest pre-op drug which we use for allaying the anxiety is benzodiazepine. Now, benzodiazepine has also shown to increase the post-op cognitive dysfunction, especially in the older patient who are at risk of cognitive dysfunction. So again, we should choose it very carefully, and it is not necessary that we should use it routinely. There are other ways of allaying anxiety as well. So benzodiazepine, right? What is the problem with benzodiazepine? Now again I am saying, as for ERAS advice, ERAS protocol advice, the routine use of benzodiazepine should not be done. So routine use not recommended. Routine use not recommended. Why? Because there is a risk of post-op sedation, respiratory depression, amnesia and cognitive dysfunction. Because with this, there is risk of post-operative sedation, then respiratory depression, amnesia and cognitive dysfunction. So that's why the routine use is not something what is advised. Now, not only this, it also causes the increased incidence of pharyngeal muscle incoordination. So risk of aspiration has also been shown to increase with the use of your benzodiazepine. So as I'm